Welcome to the AOPT Pain Sig Paincast. This is a recorded educational paincast, really, that delves into specific topics in the field of physical therapy and pain. And this week, or this episode, we have Dr. Joe Tatta, Janet Bezner, and Carey Rothschild with us to talk about the Prism Pain Recovery and Integrative Systems Model, a process-based cognitive behavioral approach for physical therapy. I came into contact with this work through a publication in this publication from last year in 2023 in the PT Journal, and I brought them in here to talk more about this. So why don't you guys introduce yourselves, and then we'll have a brief overview of the topic, and then we'll dive into a conversation.
I think one of the ladies should start.
All right, Janet, go ahead.
I'm Janet Bezner. I am professor and chair of the Department of Physical Therapy at Texas State University, and my background is health promotion and wellness. I'm a national board certified health coach, so my contribution was really around resilience, health promotion, behavior change.
Great. Carey?
Yep. Hi, I'm Carey Rothschild. I am an associate professor at the University of Central Florida in Orlando. My background is in orthopedics and sports medicine, as well as pelvic health. And my primary role is instruction, teaching, and clinical practice in the management of musculoskeletal pain.
Joe?
Hi, everyone. My name is Joe Tatta. I'm the founder of a company called the Integrative Pain Science Institute, where I train professionals on whole person approaches to chronic pain. I also do some adjunct work in many DPT programs, but the primary one is Arcadia University, which is my alma mater. I'm really focusing on chronic pain management, health behavior change focuses in the DPT program.
Great. Well, I'll turn it over to you, Joe, to share your slides with us and the presentation.
Okay. Yep. So I have a very short presentation. Should only take about 15 minutes or so. And then obviously we're all hoping to spark a conversation around all the topics that we're going to talk about today. First, I want to thank obviously Eric and everyone at the Pain Sig and the Academy of Orthopedic Physical Therapy for inviting us today to talk about Prism. And also thank you to PTJ for choosing this to be published in last year. I've included the reference down below. I also want to mention Rose Pignataro and Dr. Stephen George, who may hop in today here later. If they can, I just want to make sure that I personally thank everyone who contributed and collaborated on this paper. It was really a labor of love that I enjoyed. I know everyone else did, and I think it would be impossible without all the experience and diverse backgrounds of everyone who contributed to this paper. So thank you to everyone. So really where this came from is I had this idea of kind of evolving, or how can we improve the biopsychosocial model? The biopsychosocial model is a key model in our education and training. We're not saying that we should throw that model out. We should continue to learn about that model and use it. But how could we look at the biopsychosocial model with regard to chronic pain? And how can we evolve it so that it's more specific to really physical therapist education and practice? When we look at the literature, there has been some criticism of the biopsychosocial model. It's been fragmented and used in reductionistic ways. So oftentimes just the psychological part is applied, or just the biological part is applied. Oftentimes the social is left out altogether at times. Sometimes it's silos care. So we do have interdisciplinary and multidisciplinary pain management. Oftentimes things are kind of siloed in our healthcare system. The biopsychosocial model originated outside of the physical therapy profession. So we wanted to develop something that really spoke to physical therapy educators and clinicians. And there's been some research, which I'll show in a moment, of how it's been difficult for us as physical therapists to translate this model into practice. And then finally, the National Institutes of Health, the Federal Pain Research Strategy, has called for new or improved models. So we wanted to meet that call to action. So just real briefly, looking at the research, there's been a couple different articles on the barriers that physical therapists face with regard to implementing the biopsychosocial model. Really, knowledge and skills is probably the main one. Oftentimes, these skills are weaved into a program or they're foundational skills, and therapists are looking for kind of how can we broaden these skills. Sometimes the environment or the practice setting they're in doesn't allow for the adoption of that entire model. And then things like confidence and competence and even patient expectation, when we look at things like psychologically informed care, could be a barrier for certain professionals in applying the biopsychosocial model for pain. The other thing that the reason why I wanted to invite all of my colleagues here is that, I graduated from PT school in 1997. At that time, it was, a very biomedically oriented profession. We've really grown as a profession. Obviously, we've transitioned to a DPT, but with that, we have started to look at, okay, how do we bring in pain education into the treatment of pain? How do we add psychologically informed practice? And nowadays, we're looking at how can we promote mental health, because we see that the mental health factors are so important with regard to chronic pain management. And then health promotion and wellness and all the lifestyle factors and kind of the overlap or the interconnectedness between non-communicable diseases and different types of chronic pain syndromes and conditions that we see. So in developing a new model, we need to have a theory or a couple theories that support the model. So I did lots of research to look at different psychological models as well as social models. And I came across one that was originated back in 1979 by a medical sociologist. His name is Dr. Aaron Antonovsky. And he really had a strong health promotion approach to health, if you will. And he looked at health as, not just the absence of disease, but how do we source people with resources that allow them to maintain health and function and wellness, even in the face of current challenges, let's say. Salutogenesis is kind of a long word. It just means health and how do we create health, basically. There's a key part to salutogenesis, which is called a sense of coherence. And he started looking at this first when he investigated women who had survived Nazi concentration camps, but were able to maintain or even thrive in the presence of very adverse health conditions. To kind of summarize this model, if we look at this on a spectrum, that all of us throughout our life are either moving toward health and wellness or vitality, or moving in the opposite direction to the left toward the absence of health and wellness and vitality. And he wasn't so concerned about a diagnosis or a certain pathology, but how do we help people access resources that improves their health and moves them toward that sense of salutogenesis or health and vitality. As I mentioned before, the core principle of salutogenesis is what's called a sense of coherence. And this really spoke to me because it's a multidimensional construct. Pain is obviously a multidimensional experience. And in this sense of coherence, there's three parts. So there's the comprehensibility, which is the ability to understand one's condition, which kind of has a flavor of like pain education to it. Manageability, which is how can we tool people with the resources that they need so they have supportive pain self-management. And then meaningfulness. So can we extract something meaningful from this stress or from this condition that allows us to grow from the overall experience? So positive growth is a big part of everything that we're talking about. So a sense of coherence, which is here in the center, it is a characteristic that's modifiable. So when we add in these general resistance resources, we can help someone shift toward pain recovery or towards salutogenesis, if you will. When people are missing these resources, then they may start to move in that opposite direction in which pain persists and pathogenesis begins to become a challenge for them. There is evidence for salutogenic factors in pain management specifically. So that sense of coherence is associated with less pain catastrophizing and less kinesiophobia. It is a coping mechanism or mediator of the pain experience and improves people's health-related quality of life. There have been different conditions such as osteoarthritis and pain in the midst of daily occupations that have been looked at. And finally, there's it's small, but it's very significant as far as how salutogenic factors help people maintain physical activity participation and improve their sense of coherence down there at the bottom. A big thing for all of us, I think, is that the main mediator of change in salutogenesis is resilience. And this really spoke to us because we have had, I'll show you a slide in a moment, but we have a lot of research around vulnerability factors in pain management. But what we're starting to look at more and more are the resilience factors in pain management. And resilience is that one factor that allows people to strive in the face of pain or in the face of adversity. The second theory is process-based approaches, which have kind of really come out of the psychological literature. And process-based approaches really are just the health behavior change approaches that we're hoping to develop and cultivate in people. There are many different types of health behavior change processes that are recommended in pain management. So one of the things we want to do is start to look at really what are the key health behavior change processes that we can resource people with that leads to the attainment of pain recovery. And these process-based approaches also recommend that we should start to move beyond just identifying risk factors and looking at these mediators like resilience that are related to biomedical, psychosocial, and epigenetic lifestyle factors. So here's just a brief list of vulnerability and resilience factors. Most of this is taken directly from the OSPRO, which hopefully many of you are using the OSPRO to measure these factors. But as I mentioned before, the vulnerability factors are up top. Those are the factors that lead to poor outcomes in pain management. But the resilience factors are quite interesting because they buffer the vulnerability factors and they lead to better outcomes in pain management. So things like pain acceptance, pain self-efficacy, hope and optimism, which you see come out of the positive psychology literature, versus the vulnerability factors really come out of the psychopathology literature. Psychological flexibility, mindfulness, and then finally, health-promoting behaviors, physical activity, sleep, nutrition. These are all resilience factors that lead to better outcomes in the face of pain. So we can take a look at the Prism model and domains, and hopefully that'll start to spark some questions from everyone here. Just so people know, we did a literature review to identify randomized controlled trials, systematic reviews, and meta-analyses that supported everything that you see in Prism today. We used the impact guidelines for looking at chronic pain trials. We also looked at models that were published in the PTJ literature from 2016 to 2020. And of course, there's the combined clinical, educational, and research expertise of all the authors that are on the paper that were really key to developing Prism. So instead of biopsychosocial, we've all seen those three circles. What we came up were 6 domains. And these are the 6 areas that you would work with a patient or a client or populations when you're helping with pain recovery. So they're person context, purpose, pain literacy, pain mindset, physical capacity, and physiology. So this is not what we're doing. This is the domains where we're working in general. Now, we needed the behavior change processes to support each domain. And we had, really kind of went back and forth about which are the most important domains that support, or which are the most important processes that support each domain. And what we came up with were 3 key processes, which you can see here under each of those domains. And when you help people access those processes or train those processes, that it leads to improvements in those domains. Just one thing to note, the domains oftentimes have overlaps. So things like pain literacy have overlaps with pain mindset. And many of the processes themselves, things like beliefs and psychological flexibility, or things like embodiment and physical activity, oftentimes overlap or reinforce one another. Some things that I think are important to point out. Safety learning is a key process in the model. So that makes Prism a trauma-informed approach. If you look at the whole pain mindset, really this talks to a psychologically informed approach. The whole physiology domain and the processes there look at all the lifestyle factors and health behavior change factors. And then, of course, things like purpose and person context are really important when we're starting to look at individual factors that are related to someone's the persistence of pain as well as their pain recovery. And then just the last slide before we go to some discussion. We did kind of point out on our paper that Prism aligns with national as well as international pain strategies. So we do see it as a resource for the DPT curriculum for planning on pain education. We hope that all of you at the Academy sees that this model supports and potentially even extends the efforts that everyone's put in with regard to the pain education manual. Of course, it supports CDC clinical practice guidelines for the non-pharmacologic care of pain, specifically the opioid prescribing guidelines, as well as the NIH guidelines that look at new models. And then other things that have happened kind of like from Medicare. The CMS coding system now has 2 codes for pain management that include pain literacy and health behavior change, which are really salient in this model. One of the challenges is that physical therapists can't currently use those codes to bill. Those are only for primary providers. We hope that'll change, and Prism will spark some change there. And then in the realm of research, the NIH HEAL initiative, helping to end addiction or opioid and pain management, Prism could inform studies in that area. So those are the slides I have, and I can bring them back up, but hopefully that'll is a good intro to Prism. Everyone can, of course, find it in PTJ and read it. And then I'll turn it back over to you, Eric, for some questions and comments.
Great. Well, thank you, Joe. I really appreciate that. It was a very concise overview of it's not a long article in PTJ, but I would say it's a fairly dense article with the amount of concepts that you're introducing and intertwining. And that's one of the things that sort of attracted me to it. Someone who's spent the last, since I was hired as faculty trying to teach pain to physical therapy students, one of the things that I've sort of noticed is, and I think this is maybe a criticism of the biopsychosocial model, but is like, there's just a real lack of integration. It's like we teach a couple of things, and then we tack on some psychologically informed care, then we pull in some motivational interviewing, and then we're just like, all right, there you go. And it's not integrative, and it's not in a way that sometimes I think students have a hard time with that. So I really appreciate the work that you and your team have done in terms of trying to articulate that. That's what it seems like to me, at least. So I guess one of the questions, since a lot of clinicians will be probably, and I'll open this isn't just to you, Joe, it's to Carey and Janet as well. If I'm a clinician out in practice right now, and I read this article and I'm like trying to figure out, okay, well, how do I start piecing together a practice that is consistent with the ideas and that you're promoting here through your integrated model Prism? How do I actually do that? Because if I look at the landscape of CEUs out there, it doesn't necessarily, a lot of this doesn't line up for post-professional continuing education. So I think that would be a one question that's like top of my mind. So I'll turn that over to you all, and I could just call on somebody, or does anyone have a dying urge to try to tackle that question?
I'll take a stab at it at first. I mean, first you're in this model, you're kind of receiving the education of all of us here. So all of our experience is present in this paper. So all of us have a career of studying different things, reading different research, and interacting with different researchers and clinicians. So you see that in the paper. I do think that a lot of what is in Prism is showing up in the DPT program currently. I think we're becoming more intentional about putting that content into the program, which Janet and Carey can talk about a lot more than I can. And I do think that professionals are aware of these more health and wellness related topics that we're talking about, because we're talking about them in culture, right? It's on social media, it's in the news. It is slowly trickling into continuing education. One of the things that I focus on is the continuing education of professionals kind of in whole person pain care. But yeah, Prism is, some people have said that Prism is big, but I do think the foundational principles are there. And I'll just kind of turn it over to Carey and Janet to kind of expand upon this, and maybe they can share what they're teaching in their program and how it relates to Prism.
Sure, I'll be happy to go. I do think that the model, as it does expand upon that biopsychosocial approach, when you look at the domains and then you look at the processes underneath the domains, I think it gives not just clinicians but even educators other things to talk about with their students or with their patients, and it is definitely more comprehensive in saying that, well, have I really addressed the patient's values here? Like maybe that is something that I can work on that I haven't approached yet. If I was just stuck in that psychosocial or just the psychological piece, I may only be focusing on those yellow flags, which are great, and focusing on those vulnerability factors, but really not capturing those resilience factors. I think as a practical hands-on, you can take to the clinic tomorrow type of a nugget of information would be, are you really assessing those resilience factors? Because that is part of whole person healthcare. And maybe we don't need to address just those vulnerability factors. We need to recognize them for sure. But what is that other missing piece? And I think just even looking at the model and the 6 domains and looking at the processes, the 3 individual ones under each domain, there's so many other things you can take a stab at. And for me as an educator, am I talking to my students about safety learning? Is there some history of trauma in that individual's background that is really making them feel unsafe with basic things? There's so many processes in there that you can work on, but I definitely think from an educator, I've felt a little bit limited with the biopsychosocial approach from an education standpoint. And like you had said, Eric, feels a little disjointed. I think we're doing a lot of education about what pain is and what the beliefs and fear and things that can be interfering with that. But I do love the Prism model, and I love that I've been able to extend this as another avenue for my students to think about when they have their conversations with their patients. And then hopefully clinicians that are looking at this will see that as well.
Yeah, I'll just add that, the biopsychosocial model was introduced when I was practicing early. I've been in PT for over 40 years, and it was revolutionary because prior to that, it was biomedical, period, nothing else, right? The mind was not connected to the body. The spirit wasn't even in the conversation. So that was revolutionary. And I was one of the first PTs to say, hey, we need to pay attention to this biopsychosocial model in my early work. And now to see this, yet another model that extends our lens even wider is really exciting to me. So I think to answer Eric's question, I think it depends on when you graduate from PT school, right? And where you are in terms of how you would approach this. I think one thing I would suggest that applies to everyone is to really approach this model as a paradigm shift. That's not a new term. It's kind of an old term, but to really get our heads out of the medical approach of finding a problem and fixing it. Because we can do so much good. We can provide so much benefit if we think more broadly and we address any of those processes that are in this. Just pick one that's not familiar to you or you're not using regularly, and start to learn about it. There's so much information out there in all these areas, and I think our article does a nice job of summarizing it. But you got to dive a little deeper because it's not obvious from our paper how to have a conversation about some of these things with your patient. And we have another paper hopefully coming out, some case studies that I think gets a little closer, but they're gonna have to dive in and trial and error, and that's okay. I think that's how we all learn. But any of it, just pick one and start.
So Janet, I have a follow-up question for you. Given your background with health coaching, and the skills that can bring to a physical therapist sort of skill set, how do you envision, I don't know a ton about health coaching, but like, what is the interplay between those two things? Is that something that, I think if PTs wanted to gain some additional skills that would be complementary, is that something that they could think about? And what does that even look like?
Yeah, absolutely. I think health coaching is really a partnership with a person to help them discover their own motivation for whatever it is, whether it's doing an ACL home program or whether it's managing chronic pain, and everything in between. So it really provides skills around how to guide a person to sustainable fill in the blank, some kind of behavior. In this case, behavior change. That's primarily what we're trying to do with all of our patients, is to get them to do something that's different than they've been doing. And so I think we teach all of our students health coaching skills. I think it's starting to be one of those things that programs are starting to add, but that's a fantastic adjunct. And Joe and I are actually talking about how do we help PTs gain these skills in the area of pain, because a lot of it is not hands-on. A lot of it is from here up.
Right.
And, now we're talking about motivation, empowerment, values. Carey mentioned values. I think every PT should be thinking about patient values every time they do everything to a patient. How is this consistent with my patient's values? Because connecting with values is the key to sustainability. And there's lots of support for that. So that's a simple thing. It's a simple concept, but maybe we're underappreciating that.
Yeah. Yeah.
If I can add something there, Eric.
Yeah, please do, Joe.
As I listen to Carey and Janet talk, and they're, talking about the processes, right? Values and all the things that are in Prism. I think we should just maybe shed some light on the fact that, best pain management principles right now in physical therapy, as well as other areas, is that it should be multimodal. So it's not just exercise, which of course is key to pain management and key to our scope of practice. But, that slide I showed earlier that, pain education has developed, psychologically informed care has developed, the health promotion skills that you're talking about have developed. And we really should learn how to kind of fuse and integrate all those together for more of a whole person approach to pain. Some of the best research shows that somewhere between 3 to 5 processes, if you can start to cultivate 3 to 5 processes, that starts to really kind of move or shift the needle for people with pain. So that could be something like, for example, obviously the promotion of physical activity, let's say helping someone with sleep, and then let's say changing beliefs. So those 3 right there are 3 key processes in Prism. There are also 3 key health behavior change skills that prevent the persistence of pain from happening. So, maybe start with 2 or 3, let's say, and then as you become more skilled and you take courses and, you learn, you start to add more processes in.
Hey, Joe, and everyone else here. I think that's a really interesting point. I think the idea of processes, that might be something that's new to kind of physical therapists, or maybe that it's not a term, it might be a new term. And I'm wondering if you just want to spend a little bit of time, like why that's so important in thinking about processes. And, I guess if I put my orthopedic hat on, it's like, okay, someone's got elbow pain, they've got impairments of, joint restrictions or muscle strength or range of motion. And then that leads to sort of restricted functional activities. And then there's the participation domain if we're using the ICF model. Well, you're saying this word processes, like, how does that fit into this? And yeah, I'd love to hear from you on that.
It's a great question, something that all of us talk about all the time. I think all of us come from a very strong orthopedic background, probably from the 90s when we went to school, so to speak. And from that model, it was it was really about treating acute pain, and what was the intervention that we could use that would basically eliminate that pain, so to speak. As pain becomes chronic, you have to kind of leave that model behind, really. We're not interventionalists anymore. We are health behavior change experts. And with that, what we're really doing is we're changing plasticity in the nervous system. We're changing plasticity throughout the entire body. And that is a process that takes time. It's not a one-time event. So really what we're doing is we're supporting people in that biopsychosocial change, in that process or process of change, if you will, that helps people, that shifts people toward pain recovery. And I know that Janet's probably going to want to talk more about that because she loves talking about the behavior change processes.
Yeah, the term process, it's really intuitive on your part, Eric, to recognize that's probably new to most people. It comes from intervention science, and it also comes from systems approaches. And so Prism, I'll just go back a little further. Antonovsky, he really understood that concept before anyone else did and wrote about it. He understood that everything we do, or everything a person does, and everything a medical professional would do to a patient is related to everything else. So a system exists in a holistic situation where everything affects everything else. And so the cool thing is that Prism gives you 6 different runways to intervene and affect all the other processes, all the other domains. And so, and PTs discover that every day when they're treating patients, right? Because what works for one patient is not going to work for another. And that's, I think, a shortcoming of clinical practice guidelines, if I can just say that. Processes is sort of the antithesis of interventions because it implies fundamentally that the patient is engaged in it. So it's not something we're doing to someone, but it's something we're teaching someone to do independently. And that's really the key in behavior change. You know, what works for me, I'm skilled at many health behaviors. I do them every day without even thinking, but what works for me isn't going to work for Joe or for you, Eric. So it's helping the patient or the client figure out what works for them and why is it important to me, and then they can do it. So it's that phenomenon is a process, I'll say.
Yeah, I think it's a really different framework than we're used to thinking about. And like, I really like that aspect about thinking about engagement. And it's something that, you know, when I think about delivering good care, and one of the things when I teach pain, it's like, you know, about pain, it's like you can start in multiple places and there's not a right or wrong. You know, go with your instinct and what the patient's showing you, like have a good comprehensive assessment, but like kind of, you know, I try to teach the students there's not a right or wrong way to start with any given patient, but then what you do, what the patient does next, and then what you do next is like the dance you engage in, and that's where you start reacting. And I think that's a different mindset. And that's what I hear when I hear the word processes, is like we're engaging in that dance along that sort of process, but how it works out with individual patients is going to be different for each one. Carey, I'm really interested to hear about kind of pain education and how you merge this into the, you know, for the faculty or the educators out there that might be listening to this, like, what does it look like? What are some things that you feel like work really well in terms of, you know, experiences that you provide the students that help them understand some of these things?
Sure. I'm very lucky because I get to teach a standalone class that's 12 weeks long on pain science. And so we start off with a lot of the physiology and things of that nature, but we have at least half the courses spent on interventions, and specifically these type of behavioral interventions. We do lots of role playing. We have some interaction with stimulated patients that are patient actors that come in and they have to respond to some of these things, just even basically developing that therapeutic alliance. And once that's developed, then they can dig a little deeper and ask questions that might relate to values. I always go to values because it's kind of the low-hanging fruit you can always start with in that regard. But I've had some really good feedback with students. Now, I haven't had yet an opportunity to specifically introduce Prism, but right now I'm teaching orthopedic physical therapy. And so even in the context of an examination of an elbow, like you just mentioned, is it someone that's got lateral elbow tendinopathy that they've had for 5 or 10 years? This is a type of patient that might be really perfect for a different approach that involves more of the processes versus somebody that wants an intervention. They want something that is a one-time thing that might be more appropriate in an acute tendinitis type of situation. But I've been able to just kind of sprinkle little things in some of these processes that are under the domains, even in just in the context of an orthopedic examination. So I think that when we do get to this summer class and I get to teach this and they see the big broad model, they're gonna be like, oh, you mentioned this in this class, or you mentioned this in this class. And I also, get to teach therapeutic modalities, which, still have a role in pain management, and they do address some of the physiology, and they may contribute to, that feeling safer and being able to do things in a less fearful manner. So I hope that answered your question, Eric.
Yeah, no, yes, certainly. I think where I want to go next is kind of like going back to practice, but thinking about this idea. I think another thing that comes up when I teach students, and I'm sure many of you have probably had this, is like, how do I bill for it? How do I bill for it? And that really starts to constrain the therapist's mind. And what's become more apparent to me is practicing the full scope of our practice is where we can bill is quite a bit reduced from where we can actually practice. And I would like to hear from you all what you think about, practicing from you could call it practicing from the head up in a lot of ways, because a lot of the processes, there's obviously some parts, the physiology, the movement, the physical activity, that's kind of in our wheelhouse as PTs. But, I'd love to hear your take about, is physical therapy ready for this from the Practice Act? Is there any limitations for us doing this or doing from the head up kind of more focused therapy?
I think some of the exciting things we're seeing right now, like for example, in the military and the Department of Defense, where physical therapists really are taking a primary care provider role. Prism fits in perfectly with that. I believe we'll continue to see that in the private sector as well. I think where you're going to see that first and foremost is actually in the technology sector, where these companies that are starting with, musculoskeletal digital health, so to speak, they're not necessarily looking for people to just teach exercise. I'm actually speaking with one right now. They're really looking for practitioners with a broad skill set. And I think physical therapists, of course, with a good background in pain, health behavior change, lifestyle medicine, things that Prism offers, it allows us to stay competitive in what could be a competitive healthcare market, so to speak. So I know that there are interdisciplinary chronic pain centers that are looking for professionals with these types of skills. I think for the professionals out there who are listening to this, who are billing and coding, so we're talking about payment and reimbursement, we're not limited to what we call our quote unquote CPT codes. There's no such thing as a PT CPT code. So technically, you could use other codes, but I think the key is, one, you have to have a screening form in your evaluation. So for example, I use the pain resilience scale, which fits with Prism. And now that I have that pain resilience scale that's looking at the cognitive and behavioral factors, now I can create a plan of care that centers around those factors and use it throughout the plan of care, basically throughout the patient's treatment. I think what happens now is physical therapists start with a traditional approach to therapy, and then all of a sudden they throw in like some pain education, and then they're billing like a different code for it. And the insurance company is saying, well, you didn't mention this during the evaluation. You didn't screen for it during the evaluation or document it, so it gets denied. So it's not necessarily, do we have the code? I really think it's, do you know how to skillfully evaluate, assess, and defensively document what you're doing as a Prism-informed therapist, if you will?
I love that. I love that thought, Joe, and I would echo that. I think we're underappreciating our value when we limit ourselves, for sure. I was going to mention also that to Eric's the first part of his question, that we mentioned this in our paper. The World Health Organization recommends that non-mental health providers start delivering what they call low intensity psychological interventions. And boy, I mean, that's where coaching comes in, really. I mean, if you think about our roles as physical therapists, we're coaching all the time, if you think of it maybe in a traditional sense, but we're cheerleading, whatever word you like. You know, a lot of people have mental neck up needs that don't need a psychiatrist or a mental health provider that we can really assist with. And I think if you look at the literature on what is an expert in physical therapy, the Jensen et al. Literature, they talk about it without talking about it. They don't use the word coach, but the experts and what they saw in the experts, those are the people that can really get inside a patient's head and really connect with them and understand what they need and what works for them. That's the art of our profession that's existed for 100 years. And I think we're getting really close to being able to put language around that and make it systematic and teach it. Joe's really involved in APTA's efforts he's leading APTA's efforts around mental health. And I think this is about to explode, because who do you know that doesn't have a mental health problem? No one.
Right.
The other thing to mention, Eric, and we mentioned this specifically in our paper, is that the public is looking for integrative health approaches. So when surveys have gone out to people with pain and other consumers that have health challenges, they realize that there are multiple things that they may have to change in their life. So they're looking for integrative approaches to care. Sure, those integrative approaches could be delivered in a team. And there's definitely I can imagine Prism being implemented in a health team. But we still think that, if you think of like the stepped approach, or those step approach models like in the VA system, the first step really is health promotion, which anyone really could step into. And the second step is the primary care management of pain, which is typically a PT, a chiropractor, or a physician. And we see Prism, really fitting one of those two steps. And then kind of like you skip over the step that is interventional care, and then you're into the step that is multidisciplinary care, which Prism definitely could fit into. But I think that, the key take home is that consumers are aware of this, and they're looking for providers that have a broad skill set that can help them with their health, obviously. And I think it would behoove us to meet that need and that demand that's out there.
Great. Going back to the idea of kind of coaching, say, I'm a orthopedic specialist, kind of operated that mindset, and I want to learn about health coaching. I know that a lot of people call themselves health coaches out there, but I'm curious to know, like, what is the best way for me to gain some skills there, to get some skills that are evidence-based, that have that are good trainings, that actually teach me skills that will impact my patients?
Yeah, it's a good question. So there is an official term now called health coach, and it's a certification. It's a national board certification, and there are health coaching codes now that only certified health coaches can use. So there are CPT codes, which is great. So, but if you're just wanting to learn and you haven't had the first thing, you can Google my name and find a couple articles that I've written for physical therapists about that. It's a good place to start. And there have been sessions at CSM and other conferences regularly for the last few years on health coaching. So that's another resource. Not sure that APTA has anything separate in the Learning Center, but there might be some recorded things through some of the academies or sections. And you know what? There's a need Joe and I are going to try to fill here. So be patient. We might have something for you in a year or so.
Great. Yeah, I mean, I think I think, unfortunately, there's a lot of really self-directed therapists out there, but then a lot of therapists get really stuck about, like, they can only feel like there's so much of their education is so psychomotor, so active, and that this is like a hard, I see this in teaching in our third years. There's 2 years of psychomotor work, and then they get to the third year, and then you have to ask them to think. They're like, I just want to do stuff, and that's part of the challenge with our profession, is saying, okay, let's slow down and focus on what's going on between your head before you start going and doing stuff. And so I'm always really just trying to find better resources to direct people and look for my own inspiration with my teaching and whatnot. So, I'm super supportive of this work and like where it's going. I guess from when I looked at those slides, this might be the last question we get to, unless but when I looked at the slides, when you looked at, let's say, the resilience factors and the vulnerability factors, I think that was a slide. There's a lot of research that supports, pain catastrophizing, fear avoidance, pain acceptance. It may not always be in the PT silo. Some of it might be in, psychology or other related disciplines, social work. But it seems like there's a lot of empirical support on the various domains. But I guess I'm wondering from your perspective, what's maybe a next step in really, like, from an evidence-based perspective or from a research perspective, maybe to that either Prism can inspire or Prism could utilize.
Yeah, I mean, it's a great question, Eric. So the next step for us is we've been taking this model, we've been looking at the different processes and domains, and starting to operationalize it so that we can test it further in studies. Jana mentioned that we have a case series that'll be published soon. So that's kind of like our next step from there. And then from there, we'd like to run some kind of trial once we've operationalized the model a little bit further, so we can collect some data and be able to share with people more about, what do we think are potentially some of the most important processes, let's say, in the model that help people with chronic pain. If I can just backtrack one moment. So you're asking about resources and things like that.
Yeah.
So we have there's a textbook out there called Integrative and Lifestyle Medicine in Physical Therapy, which, full disclosure, I'm one of the chief editors on that, and Janet has authored the chapter on health coaching in that textbook. But that textbook is utilized now in a lot of DPT programs because it covers a broad range of a lot of the things that we're talking about today. So if you're looking for kind of a evidence-based textbook for, let's say, DPT program or even clinical practice, I would point people to that book, and it's a good place to start.
Great. Thanks, Joe.
And I just wanted to piggyback on that, if I may. So Eric said there's a ton of research on those vulnerability factors. Yes. There's also a ton of research on those resilience factors, but it's in healthy people. It's in well people. Mm-hmm. And so what we're really trying to do is marry those bodies of literature, because, the people who, especially people with chronic pain, those factors, they go haywire. And so, and that really leads to these pain catastrophizing and other things. So it's really helping people get back to their human sort of roots, of well-being. And those are in all of us. Those are in every one of us. And the extent to which a physical therapist can draw those out in a patient will improve outcomes in every aspect of physical therapy. In Carey's work with musculoskeletal, I don't know your practice area, Eric, but I'm guessing it's musculoskeletal. You know, I used to do cardiopulmonary. Man, I was using those things before I knew what to call them, and they worked all the time. And so it's really getting our heads around taking what helps people be well and successful and marrying it with the pathology that we're really good at. And that just doubles our toolbox. So it gives us a lot more ways to reach our clients. And it's really exciting because that stuff is fun.
Yeah. Well, I think that's a great point to end on. So I want to thank you all for taking an hour out of a very busy day leading into CSM to talk about your article, to talk about your ideas, and to share kind of your knowledge base with the PT profession more broadly. So thank you all, and I look forward to catching you.